Welcome to this summer meeting of the Southwest Neonatal Forum. Obviously we are doing it slightly unusually with the video here, and hopefully you'll find it interesting. Obviously we're going to pass on to a number of webinars in a second. Just to get the house rules, as you can see, you must have all, I think, found the YouTube channel. You will see down the side there, you can put questions and comments as it goes. So I'm hoping the speakers will be able to be listening with us and may answer the questions directly. Otherwise, others feel free to chip in, because that's sort of what it's about, and it's also what we're missing out by not meeting up down in Taunton. And well, without more ado, I was going to pass you on to Dr. Pam Cairns. I think she's well known to many of you as one of the consultants up in St Michael's, who's always really helpful when you've got a sick baby. She's got a particular interest in ethical issues related to neonatology, and is currently actually doing a PhD, of which I think babies with short guts forms part of her thesis. Anyway, that's the subject she's going to kick us off with this afternoon, exploring the ethical dilemmas around babies where most of their gut has been injured. So, well, without more ado, I'll pass you over to Pam. You'll hear her voice over the slides, and as I said, feel free to put in questions down the side. Also, as the afternoon goes on, comments about how well you feel this has worked. Anyway, I'll talk more about that a bit later on. Anyway, over to you, Pam.
Afternoon, my name is Pam Cairns. I've been a consultant in the neonatal unit in St Michael's for the past 20 years, and more recently I've been doing a PhD in the Centre of Ethics in the University of Bristol, particularly looking at practical decision making for babies with short gut. So why would we need a framework to help us make decisions for these babies? Well, over the past 20 or 30 years, the management of intestinal failure has improved significantly, and the survival rate is now dramatically better, certainly than it was when I started training. Alongside of this, as we all know, very preterm babies are now surviving in increasing numbers. But we're still seeing necrotizing enterocolitis, which in some cases will cause a loss of a lot, if not all, of the small bowel. And many of these babies have the potential to survive as well. And there's been a lot of debate into which babies it's appropriate to give active care to, which babies one should really recommend palliation, and whether parents should be allowed any input in the decision, and if so, for which babies. And anecdotally, I would say that in my experience, there's a lot of variation between individual clinicians and how they feel these babies should be managed, both between professionals across different units, but also between different specialties, and I can see that through my work in the Clinical Ethics Committee as well. So, although anecdotally I'm aware of some variation, I thought I'd start with finding out whether there is indeed any variation across the country, because in fact if most people agree, then actually we don't need any additional framework to help support decision making. So last year I carried out a survey using SurveyMonkey for paediatric surgeons, gastroenterologists and neonatologists. It was very short, took about 5 minutes to complete, and looked at a number of short scenarios. And I really wanted to get a feel for what professionals believed about the prognosis for various cases, about the ongoing quality of life, and how they would approach decision making, in particular when they thought parents should be allowed the final say. I sent this out twice and had 147 respondents, which, given the relatively small number of units who look after this type of babies, was a fairly good response. But then I split the responses by specialty. Now, I've just shown the surgeons and the gastroenterologists in comparison here, because actually neonatologists' answers were pretty much identical to the surgeons. So this is where it gets a little more interesting. So you can see I've graded the answers from very unlikely or unlikely in red through to likely or very likely in green or dark green. So the more green you see, the more optimistic the answers are. So this was again looking at the same groups of patients with very short guts. And as you can see, if you look at the less than 20 centimetres, so this was the group that most people felt will probably go home in PN, but may get to full feeds. If you look at the less than 20 centimetres, more than half of gastroenterologists felt that it was possible or likely that they would achieve enteral autonomy. Compare that to the surgeons on the right-hand side, where only about 10% of them felt that was the case. And if you go up to the babies who've got less than 40 centimetres, more than 70% of gastroenterologists felt it was likely or very likely that they would achieve full enteral nutrition at some point, whereas less than 50% of surgeons felt it was likely and none of them felt it was very likely. So there is quite a difference between how different specialties regard the chance of coming off PN and onto full feeds. The other thing we of course look at in these babies, it's not just all about can you come off PN and eventually get onto feeds, but it's very much about the quality of life. So we asked a couple of questions, and this is just one example. And this is a term baby with extremely short gut. So it's an otherwise healthy term baby who has a short gut secondary to volvulus. So one would expect that the development of this child would be otherwise normal. They would not have any other health problems. It would simply be that of their gut. And then we're asked to reflect on what a good quality of life, likelihood of a good quality of life at school age. So you can see, again, on the right-hand side, gastroenterologists are very optimistic. They all felt that it was very likely or possible that they would achieve a good quality of life, with more than 70% thinking it was likely or very likely they would have a good quality of life. Contrast that with the surgeons and neonatologists, where only 20% felt it was likely or very likely. So a difference between 20% and 70%, that is quite a difference. So you might be thinking, well, this isn't really an ethics talk, is it? But actually these things influence how we make decisions. But it isn't simply a matter for ethics. There is a right answer to this, isn't there? How many of these babies will get onto milk feeds? What is their quality of life? These are measurable outcomes. So of course we can't just reflect on our own anecdotal experience, because that will be influenced by our own practice. So we go to the literature, as one might expect. I think this point, and again I'm not going to go through the literature at all because I think Tony might have done that, but it must be recent. As I said at the beginning, the prognosis has improved a lot over the past 20 years. So any patient group before that is really not relevant to the current day. It is really important that it's generalizable to your patient at the point in illness at which you're seeing them. So if you're seeing a baby that's at 25 weeks and has just lost most of its gut, while it might be interesting to know how well children who are on home PN in an intestinal failure clinic do, that they might not be the same patients as the patient who's the one in front of you. And the reason for this is what I call the prognosis pyramid. So at the point of surgery, if you have a baby who's a preterm with short gut secondary to neck, we know from the literature that many of these babies don't survive to hospital discharge. Some of them will die around the time of surgery, either because of overwhelming illness or because of a decision to palliate. But some of them, despite the decision for active treatment, because of the degree of illness severity and the complexity of TPN and infections and liver disease in these tiny prems, a reasonable portion do not survive to hospital discharge. So the patients that then make it from the neonatal surgical unit onto the home PN group of patients are not all the same patients. So reflecting back on the literature, much of it is about groups of home PN patients, and these are very good and very useful studies. But it all depends on how you use them. So it's just important that when any of us are giving prognosis or trying to guide parents as to what the future would look like, that we really, really try to think about where the patient is at that point in time. So given that we know that, I guess the question then is, we might all make different decisions for individual patients, but faced with a theoretical patient, how do we make decisions? Do we all approach it in the same way? So this was a 28-week gestation baby with short gut, as I said, 20 centimetres, but with bilateral brain hemorrhages, so interparenchymal hemorrhages, grade 4 hemorrhages. Should active treatment be offered? So this baby is likely to go home on PN, and given that they're preterm, they've had severe neck requiring surgery and have pre-existing brain hemorrhages, they're very likely to have significant neurodevelopmental impairment. So what do different people think? Well, again, you can see just from a quick look at those figures, the surgeons and neonatologists are fairly similar, and the gastroenterologists, again, look a lot more positive. There's much more green on their side. So the bright red at the bottom is for the group of consultants who felt that this treatment should not be offered, should not be made available. They would be prepared to go to court rather than be forced to do active treatment on this. And that was about 20% of surgeons and neonatologists, slightly less gastroenterologists. But a much larger group felt that palliative care should be advised. But if the parents wanted active treatment, they would support that, although it would not be their advice. So a much greater portion of surgeons and neonatologists thought that, but relatively few gastroenterologists. Equally, there was 1% of neonatologists and about 10% of gastroenterologists felt strongly that the child should be treated, and again would go to court to force active treatment against the wishes of the parents. In the same way, for example, as if you had a baby with Down syndrome who had duodenal atresia and the parents didn't want treatment, you might want to actively treat against their wishes. So you can see, just looking at that a set of parents, different sets of parents with the same baby, the same prognosis, would be given completely different options, or in fact may not be given options, entirely dependent on which clinician was counselling them. They might be given an informed choice, told they could make a decision either way. They might be very likely to be advised for palliative care. They might be very advised for active care. And equally, they could have a clinician who'd be prepared to go to court to overrule their treatment, either to stop them having active treatment or to force them having active treatment. So there's no consistency at all. And this is really the reason why I wanted to develop this framework to help with decision making, really to help with consistency, so that we're all on the same page and parents are being offered the same choice. So how do we decide when parents should be offered a choice in general? Well, I think some of you have heard me before talk about the zone of parental discretion, and that's the gap between the decisions where you're making it completely in the best interest of the child, and the parents are asked to consent to that, but actually not make the decision, or things that you would not allow the parents to force the child to have. But it's the things that between you can be happy to decide with the parents. So going back to the case we've just discussed, the areas which would be within the zone of parental discretion would be those middle three. So palliative care would be advised. Parents could be given a choice, or active care would be advised. But at the end of the day, the parent's choice would decide the treatment that the child got. And that would be within the zone of parental discretion. So if you're deciding that, how do you do it in practice? Well, it might be very obvious, or you might need a multidisciplinary team meeting. So in this case, for example, as you can see, as I've shown at the beginning, different specialties have very different views. So you may need to have some representatives from surgery, gastroenterology, and neonatology, both nursing and medical, really to nail down what is the prognosis for this particular child. How difficult will it be to provide the treatment? Is it possible to provide the treatment? Are there choices that these parents could be given? And agree that together. And it may be that different people in the room feel that you should be active treatment or palliative treatment, but as long as you can all agree that at the end of the day you will be prepared to let the parent make that choice, then those can be offered to the parent. Now, many of you are probably thinking, well, actually the most important people in the room are not in the room. And I would say at this point, don't include the parents. From experience, parents, even well-informed medical parents, find this hugely distressing to listen to. As professionals, we need to be able to have a frank discussion. You need to be able to tell your colleague you think they're wrong, and give evidence for why you think they're wrong, without making them look small in front of the parents who may be their patients at that time or in the future. You want to be able to disagree with each other, and you really want to be able to talk about things that the parents may not be aware of, or in fact may never need to be aware of because it might not apply to them. So having a professionals meeting where you can air things in a very frank way is very, very useful. And how do you define these treatment options? Well, as I said at the beginning, there's the ethically obligatory treatments, which actually on a day-to-day basis is probably most of our treatments, isn't it? We would usually feel strongly that we should treat a baby in a particular way, and if the parents disagree, we spend a lot of time persuading them, on occasionally having to seek court order, but usually just persuading them to be treated the way we think the child should be treated. There are other things that even if the parents wanted them, we would think shouldn't be done, and we wouldn't do them. But there's things in the middle. There's the things where we recommend, but if the parents really don't want it, we'll accept it. So one might be vaccinations, for example. We recommend vaccinations, but we don't force parents to have vaccinations. There's other things that you wouldn't recommend, but in fact you might go along with. And sometimes it really is, you are quite neutral, and you could see that either way might be acceptable. So once you've had your professionals meeting and you've looked at all the options, the question then is in fact is there more than one option? And in many cases there might not be. It might be that everybody agrees that this child should be actively treated, in which case you're going to spend a lot of time counselling the parents about that. Most parents will agree. Some parents might be very anxious and might need a lot of time. Occasionally you will get firm ongoing dissent, in which case you might need to take this to the clinical ethics committee, or even end up in court, very rarely. But if there's more than one, genuinely more than one option that the clinicians could live with, then that's when you take that to shared decision making with the families. And for that, they need to have good information. So they need to have as good prognostic information that's relevant to their situation as you can manage. And it needs to be about more than just will they get onto milk feeds, how much time will they spend in hospital, what is their chance of survival. Most parents and families want to know what it's really like to live with a child on PN, what it's like for the child. Will they be happy? Will they be miserable? Will they have friends? There's lots of things that parents want to know about lived experience. And what's not really helpful is a lot of the literature which tends to talk in terms of quality of life scores, which are fairly meaningless on a day-to-day basis. And as clinicians, our views on the quality of life are often wrong, because what we value and think is important is often not what parents value and think is important. So this is where the experience and sometimes the communication with other families is really vital. But ethically, we often wonder what are the things that we should take into consideration and what things are reasonable for parents to take into consideration. As we said, obviously the prognosis is vitally important. Sometimes we can get a bit hung up on the prognosis for the individual organ that's a problem. For some children, that is the only problem, but it's important to look at comorbidity. What other things are going on in that child? They might have other things that in and of themselves are a problem, but not an overwhelming problem. But put together with the short gut, how much burden is that for the child? Are there other things that is going to give the child a short life anyway? Are there other things that are going to impair their ability to enjoy life, to experience positive experiences? What are the other things that might get in the way? What is the family situation, and what about the interests of other children? Now, traditionally, we look at best interests in the child as if the child is a little island. But in fact, the family, siblings and parents' happiness and ability to care for that child impacts on the child itself, but also the situation with long-term TPN will impact on the family. It will have huge financial implications and implications in terms of holidays, other activities, the time that can be spent with other children, etc. And can that be taken into consideration? Some people would say it can and should be, and other people will very much say, no, that's not relevant. So that's where the next bit of my study comes in. And I have to say, this is the bit that I'm going into, so I haven't done this yet. So the next bit of my PhD is going to be looking at a qualitative study to really try to drill down and answer some of those questions, both by getting the views of all the stakeholders, parents, children, and professionals, but then combining that with a detailed analysis of the literature, looking at best interest and views around parent decision making, and particularly for these decisions where there's a long-term burden to the child and to the family. And eventually, I hope I will be able to come up with a practical framework to support decision making, not in terms of deciding which children should be treated and which children shouldn't, but really around how to make the decision and what things are relevant and ethical to consider and what things are really not relevant. So in conclusion, I haven't given you any answers, have I? But I hope I've emphasised that good ethics always starts with good facts, and sometimes we tie ourselves in knots over an ethical problem where the problem isn't the ethics, the problem is that we actually don't know the facts. And maybe we need to seek out more information. In all these situations, you really need to think about the whole child. It's about looking at the child and the family holistically, not just the clinical question that comes up acutely. And then I think sometimes it is useful to actually formally sit back and think, where are the boundaries in this situation for parental decision making? Is this reasonable? Is it not reasonable? I think you have to be fairly sure you're right before you overrule a parental decision. And ultimately, I think we all need to remember that reasonable people might come to different decisions. You may strongly feel that child should be actively managed or palliatively managed. But it's possible that people who are equally wise and equally knowledgeable might come to different decisions. And I think we all need to understand that, particularly when we're trying to make decisions in these very, very difficult situations. I've probably given you more questions than answers, but thank you for that. And if you invite me back in a couple of years, I might tell you the answer. Thank you.
Thanks, Pam. That was excellent. It's really interesting. Hopefully you've had some questions as it's gone through. If you didn't get a chance to ask Pam a question, still put it up on the side there, just there, and then we'll try and get to them as we go through. Otherwise, we're going to stay on the same topic now, and I was going to hand you over to Dr. Tony Wiskin. He's one of the paediatric gastroenterologists at the Children. It's always really helpful if you've got a patient that you need to discuss with him. And again, this long-term TPN is one of his special interests. I know we've recently shared a patient who now, at between 3 and 4 years, has managed to grow enough gut, so she is now certainly having a trial on enteral feeding, having stopped the TPN. So anyway, I think Tony is probably going to fill us in about the subject, so over to you, Tony.
Hi, I'm Tony Wiskin. I'm a paediatric gastroenterology consultant at Bristol Children's Hospital. I look after a number of children with intestinal failure and lead the nutrition support team in the hospital for STUP. I've been asked today to talk about paediatric intestinal failure, or what others might know as home PN. What we're going to talk about today is a little bit about why children end up needing home PN, think a bit about what happens over time, and then to discuss a little bit more some cases, because that's the interesting bit, and to think about what the longer term outcomes are. So, why do children end up with intestinal failure that requires home parenteral nutrition? Largely, the reason for intestinal failure in childhood is due to congenital problems. This may be because of structural problems with the nerves and muscles surrounding the gut, problems with the gut lining, or congenital anomalies that require surgical intervention and therefore lead to short gut. Equally, necrotizing enterocolitis as an acquired condition may require surgical intervention and large resection, which again would lead to short gut. So in the figure here, we've got gastroschisis and also small bowel atresia. This combination represents the largest group of children that we see on home PN. We do see children who've had malrotation and volvulus, as shown in the figure. This can lead to significant small bowel ischemia. Again, requires significant resection. We see mucosal disorders. These tend to be more rare, things like tufting enteropathy, phenotypic diarrhea, and we also see paediatric intestinal pseudo-obstruction, such as shown on the plain X-ray there. Often these present within the first year of life, and we can talk more about them a bit later on. What makes managing children with intestinal failure and parenteral nutrition dependence different to adults is the process of intestinal adaptation that happens within the small bowel. And while this does happen in adults, the advantage that children have is of growth over time. So we know that when a baby is born, they might have around about 1 metre of small bowel, and that as an adult you have around 4 or 5 metres of small bowel. So that tells us that as people grow, their small bowel lengthens. This figure shows some data from autopsy specimens of the length of small bowel for children who died of unrelated bowel conditions, and demonstrates clearly how the bowel grows with age. So the importance of this is that if you're, as a result of short gut as a neonate, if you have 50 centimetres of small bowel, then there's still an expectation that that might grow to be 2.5 metres of small bowel by the time you're an adult, which would be more than enough for you to be able to get your nutrition enterally. So this is a real thing that we have within paediatrics that the adult services don't have, and it's perhaps why we remain so hopeful as gastroenterologists looking after these children as to what we might expect long term. So alongside actual gut lengthening with growth, there are also efficiency savings that happen within the gut of someone that's had a large resection of small bowel. So we call this process intestinal adaptation, and there's a number of things that the gut is shown to do in response to this situation. So number one is that there's often a degree of dilatation of the small bowel, and some people have looked at strategies to increase what happens normally with the idea that by increasing the dilatation, you increase the surface area available to passing nutrients, and therefore you get more absorption. The gut has other ways of managing this, and that's by increasing the length of the villi within the small bowel. So you see hypertrophy of the villus length, and you see deepening of the crypts. And what this leads to again is the ability to get more absorption of nutrients through a defined length of small bowel. These things happen as a result of normal hormone responses that drive these changes. One of the things that's key to promoting this intestinal adaptation is ensuring that there is a flow of nutrients through the gut, and that we're trying to promote as much normal GI physiology as possible in order for these changes to take place. Right, so on to the more interesting bit, which is about some cases. I have to apologise if I keep sounding like I'm dictating clinic letters and adding full stops and things into it, because I am dictating this with the usual dictaphone, so bear with me. So this is a little girl who was probably in the last, she's now about a year or so. So I first heard about her from a sort of email chain of events from the neonatal unit and the surgeons. So this is a girl born at 33 weeks. She had gastroschisis with not quite completely vanishing gastroschisis. There was still a very small defect in her abdominal wall, but there was clearly ischemic gut on the outside, and at laparotomy, the gut on the inside didn't look much good either. so there was a volvulus internally. What the surgeons had been able to do is sort of chop out the dodgy bits. There was about 22 centimetres of small bowel, but actually 10 centimetres of that looked slightly suspicious. Wasn't quite sure whether that was going to remain viable, but that was all left in, and effectively it was sort of clipped and dropped and left in. It was noticed that her colon looked small, looked short, and there was clearly no ileocecal valve there at all. The rest of it was all right, actually. So she wasn't needing any respiratory. She was needing sort of very little respiratory support. Her blood pressure was fine, lactates were fine, but certainly there was lots of just dark green yuck that was coming up her NG tube. And head ultrasound scans looked all right. So the picture that had been painted to the family was very bleak, and I guess appropriately so in those early stages, because she had the potential to get very unwell with this bit of bowel inside that may eventually really become more ischemic. It looked that dodgy. And parents were quite young, so they were in their they were late teenagers, and I think overall the picture was very bleak. There've been lots of discussions around palliative care, and then the bits that have been discussed from a sort of short gut perspective were that this child would need multiple surgeries, would need intestinal transplant, and that the outcome of that really isn't very good. So I went up to the neonatal unit and probably painted a very different picture. We've had sort of discussions around that, and I think it's there's bias on all sides really over the cases that we see. So I tend to see the kids that get out of the neonatal unit and are doing okay, and so therefore think, well, managing short gut on the neonatal unit shouldn't be too much of a challenge. Obviously, neonatologists see a lot of children who don't get out of the neonatal unit, who have significant sepsis or other comorbidities associated with gut defects, who get liver disease and die. And I think it's important that we acknowledge those biases. It was interesting chatting to some of the staff nurses on the neonatal unit, but actually there wasn't very much understanding of actually what the outlook for kids who've got isolated gut problems can be. So it's helpful to be involved in meetings like this to try and sort of share the experience of what we have and what the outcomes are. So I trundled up and I explained to the family what I thought might happen, which is that actually this girl doesn't have any particular problems. She has an isolated gut problem. Even if 10 centimetres of small bowel was resected, that would lead to 10 centimetres of small bowel still being in there. That alone wouldn't be an indicator to me to offer palliative care, as we look after a number of children that are never going to get off PN, but that actually with 10 centimetres of small bowel not ever getting off PN isn't a certainty, that actually there are children with 10 centimetres of small bowel that do get completely off PN in childhood, and that certainly intestinal transplant isn't something that we even think about, and that this is sort of something that very much we train people up to manage. So a positive option, which I think parents are very grateful for, but still remained guarded in terms of actually she could still get very, very sick with the bowel that she had. So what then happened? Lots of joined up thinking and chats between surgical team, neonatal unit and the gastro team. We had a sort of phased transition down to the children's hospital. So we try and do that as a bit of a recon process, so parents aren't going from the intensity of the neonatal unit to what they see as the neglect of a children's ward. That's all explained to them, reasons for the differences. They get a chance to come and have a look around the children's ward and understand what they're there for, and that actually they don't need an intense level 1 or level 2 environment, that they're there for supportive care really. And that we then sort of do all the training of parents to get them ready to go home on PN. So that's what we were doing. The biggest issue we had with this little lady was her JEG site. So you got a picture of her JEG site. So what we ended up doing is the blind ending loop of bowel that she had that was clipped and dropped, a Foley catheter was put in that. That was brought out to the surface initially just to provide drainage. That seemed to cause loads of leakage around it, so she ended up with a jejunostomy device, again to provide drainage, but endless problems with it. And the stoma nurses were amazing. Mum was amazing, frankly, at trying to find a way of allowing the skin to heal without it getting too damaged, because fundamentally, this was always going to be a difficult thing to manage. And you could ask, well, why on earth wasn't a stoma just done? And that's a fair question. The challenge with doing a stoma is you're going to lose something between 2, 3, 5 centimetres of small bowel in doing a stoma. And so when you've got such a short length, and actually some of it looks pretty dodge, then that's not really what you want to do. So we got to a stable position where actually the JEG site was miserable, but it was okay, and it didn't seem to be causing too much distress to her, and we got her home, and she did really, really well at home. So it was quite surprising how much intake that she could get without having a huge impact on the losses that were coming out of this, what is essentially a very, very high stoma. So she got to the point of having about 300 mils of milk a day. She was having 2 or 3, bits of stage 1 foods a day, sort of sometimes taking, half to a whole jar of baby food. She still had a significant amount of PN, but actually she was doing well. There came a point where she sort of did a little bit less well. So she was just over a year, and she was having some green vomits intermittently, and the JEG site was just becoming more and more problematic. And my suspicion of what was happening here is that the bowel dilated up to a point where actually we're starting to run into problems. So dilatation of small bowel is a thing that we want. It's a helpful thing, but actually when it gets to a point where it becomes dysmotile because it's so dilated, that's where we run into problems. And actually sometimes what you can see is a bowel loop gets so distended and dysmotile with it that you actually end up with perhaps even a volvulus occurring, which is really, really bad news. And we've seen that in some of other children, and that's then led to further resection. So at this point, more discussion with the surgeons. And so this is where having really good links with the surgical team is so important, that we can have discussions around the fact that actually, from a medical point of view, we've got where we are. Actually, we need surgical intervention now. What are the things that that we think of as gastroenterologists that the surgeons could do? What are the things the surgeons think they could do? We have a bit of a powwow to try and work out how we're going to move forward. So we decided to bring her into hospital. and with a view to doing a number of things. Closing the stoma site was one, so closing this jejunostomy, because the other problem was that this was just so sore and no one was getting any sleep at night because of how sore it was. Anything touching the skin around it was causing major problems. So number one was looking at actually can we close that. So putting the small bowel in continuity with the large bowel. And number two, looking at, well, what have we got in the way of small bowel? Are there any options for a bowel lengthening procedure? So these are bits from her op notes, and what we found at laparotomy. I say we. I was not involved in this. This was Mr. Garrett Cox. We couldn't have asked for better, really. Actually, so you can see in that figure, she's got the DJ flexure. She's got about 20 centimeters of, fairly reasonable looking small bowel, and then she's got another sort of 25 centimeters that's dilated up, and you've got the jejunal stoma tube in the end of that. And so what Mr. Garrett Cox was able to do was something called a Bianchi procedure, serial trend. I can't really know. I'll give up with trying to explain the long version of what that is. But basically, what that involves is you make a longitudinal incision along the length of the bowel. You use the fact that the blood vessels are on one side and sort of curve around the side of the bowel, as you can see there, to make two tubes of bowel. You then sort of stretch those blood vessels and put those two tubes of bowel back together, one running into the other. So you've doubled the length of the bowel, even though you've kept the sort of total surface area the same. You've doubled the length of it, and then you sort of plug that all together. So that's what happened with her. So she's gone from having what we thought was about 20 centimetres of small bowel as a neonate with 10 centimetres of it that looked pretty dodgy, to a year of age having 45 centimetres of small bowel. She's then had a Bianchi procedure, and so we've got about 70 centimetres of small bowel going into a colon. I'm not quite sure how long that colon is, but then what you then have to do is watch and wait after the surgery to see where you're at. So this is her post-surgery. She was in for quite a bit. There was quite a lot of green stuff coming out of the end of your tube for a while, but that slowly settled down. There's obviously a lot of suturing involved in this sort of procedure, so potential for anastomotic leak is there. And so we were very cautious, leaving her nil by mouth for quite a number of weeks. The biggest thing is that everyone's able to sleep at night because she's not sore from the really sort of excoriated jejunostomy site. The one thing you're not quite sure about is when stuff starts running through the bowel is how well is the large bowel going to cope with the absorption of water and bile salts, and is that going to lead to a really sore bottom, which for her actually hasn't been too bad. She does need regular Ilex cream on it, otherwise it does break down, but actually she's managing that really well. And in the last few weeks what we've been able to do is to start her on some diarrhea, because she seems like she's starving. She's looking at everyone's food and going, what about me? So she's having some diarrhea, 20-30 mils, about 6 or 7 times a day, and she's managing that really well. And so we're going to build that up to milk and then to food, with the assumption that actually this step change for her will enable us to reduce her parenteral nutrition dependence. Because actually 70 centimetres of small bowel at this stage is pretty good. With how well she's done with eating and drinking prior to this, there's real options that she'll make good progress reducing her parenteral nutrition dependence. And one of the key things in this that makes this a sort of quite good story is about the fact that actually we've been able to preserve a healthy interest with food and eating and drinking. Where we run into massive problems is where we have kids whose guts seem to work, but actually they've habitually had so many problems with eating and drinking that they refuse to do it. So that's one thing that's really key for this group. So next is a patient I acquired when I started in Bristol about 5 years ago, who was a gastroschisis. I identified antenatally, but was delivered in a DGH, transferred up here and had very dodgy looking gut on arrival. Had a stormy time in hospital with lots of issues with his gut in terms of bilious aspirates and blowing his abdomen up, sepsis associated with it, real problems. But eventually was discharged. So they were 6 months old by the time they were discharged on home PN, and we definitely did things a bit slower in those days, having got the family trained up. So this just shows a little bit about his surgical path. So this was day one, again sort of ripped from his op note. So he just had this horrible, blob of bowel, bit of dead bowel. Can't really make any anatomy out of this apart from going, crikey, that's not looking good. So his initial surgery was to sort of separate what seems to be large bowel from small bowel. That's about 20 centimetres of small bowel left there, very short large bowel, 13 centimetres there, and went on to have a step later on. So this was around sort of 6 weeks, couple of months, and the gut put back into continuity. So a step is a different type of bowel lengthening procedure, as we talked about the Bianchi, which can also be termed a lilt. So a step is a serial transverse enteroplasty, I think. Essentially, it involves cutting into the sides of the bowel, almost like creating W's or M's along the length of the bowel. It's a much more crude, simple operation, as you just fire a staple gun in here, and that way you can allow a sort of concertina effect, which then stretches the bowel out. One of his further surgeries, about 4 months of age, he was noted to have 55 centimetres from pylorus to his anastomosis, so that 20 centimetres was stretched up to 55. Some further bowel within that was dilated, so he had a further step. We don't tend to do as much of this recurrent step surgery as we used to, because the trouble with it is that it seems to affect the motility of the bowel in a way that the Bianchi doesn't seem to. And that makes sense if you just fired a staple gun across the middle of it. That sounds a bit crude and demeaning to the surgeons, but I think they'll, in their own words, they probably would say it's not the most technical of operations. So he sort of grumbled along all right, really, not making massive improvements in terms of his ability to get off PN. Did have some interest in food, picked at bits. Like a lot of the kids that we see that've got gastroschisis or atresias and things, they come from families that aren't necessarily the most stable, and lots of problems with mum and dad splitting up and various boyfriends coming and going, and lots of other kids in the household. So really difficult for mum to manage. Gradual sort of withdrawal from dad, really, of him doing less and less. But then we got to a point where actually it was really interesting what was going on with him, that he just seemed to be drinking. He was just drinking absolutely truckloads, and he would drink from the toilet. He would just drink so much. Wasn't interested in meals, but was drinking, and would throw up. Would just throw up huge amounts. So this just wasn't really sustainable. It wasn't clear what was going on. The reporting from the family was difficult to understand. His bloods were just looking fairly, the electrolytes were stable, but his urea was up and down. It just wasn't clear what was going on. So we pulled him into hospital, and it was very evident that he was dehydrated. Ultrasound scan showed he got nephrocalcinosis, and what happened, we sort of observed him in hospital, and what we could demonstrate really is that any time he had anything going into his bowel, be it just water, diarrhea, squash, milk, anything just led to significant electrolyte disturbance. He would vomit. He would have lots of loose stools. As we tried to do an upper GI contrast, which showed that things just sluggish through the duodenum, but did eventually run through. We did a scope because we were wondering, is there some sort of mucosal problem, or can we? Part of the reason for doing a scope was thinking, well, have we got a problem in the duodenum? Can we bypass that with the Jedge tube, and can we put that in a scope? But I mean, we couldn't actually really get through his duodenum, so we could get sort of from D1 into D2, but couldn't really get beyond that. We talked to the surgeons about, does he have another laparotomy to have a look, see what we've got? Could there be some small, kink there that's causing the problem? Surgeons were very unkeen, and I think that's perfectly fair. His previous surgeries, things have been properly stuck, difficult to get into his abdomen, and the potential for him to just have some really long post-operative recovery was there. So he was actually discharged nil by mouth because it wasn't safe for him to have anything. So that's quite heartbreaking for us. However, what's encouraging is that he is making progress. With reluctance, we've managed to convince Mum to start using his gastrostomy again. So he's getting some blended diet in there. He's taking stuff by mouth. He's enjoying food. He's drinking sensible amounts. He's not being sick. He's toilet trained. His stools are still pretty loose, but they've managed that. And he goes to school. He has his PN. It's over 7 nights a week. Goes in over 10 hours because that's what's practical. Normally we don't try and give it over that short duration, but he's a bit of a tinker. He will play with his pumps and lines and all the rest of it when he's sort of not quite dopey enough for sleep. So they tend to put him down and then sort of connected, but then set everything up when he's sleepy. He goes to school. So he's 5. He leads a pretty normal life. He picks up packed lunches, has bits at school like many kids do. He just tops it up with his PN every night. His growth is all right. It's not fantastic. I think we've got a bit of work to do there, but otherwise he's well. He's not had any emergency hospitalisations for a very long time. The admissions he's had have been elective ones organised by us, so he's doing really well, despite the fact that his gut is pretty rubbish, and that's principally an effect of gastroschisis that we sometimes see. As you know, that some kids with gastroschisis just have really naff gut. Not being helped in his case, I think, by the number of steps that he's had has probably further reduced how well that functions. So the next one's quite an interesting case that involved quite a lot of team working with other teams. Baby term delivery, no antenatal issues, older siblings who are fine. Came into hospital day 3, bilious vomits, discharged following had a unremarkable, really contrast study, I think, but was readmitted a couple of days later, just clearly no better. Weight losing, vomiting green. So it became clear that he had whole gut aganglionosis, so total gut Hirschsprungs, and also bilaterally dysplastic kidneys. So this was a really challenging one of, well, what to do next. So different to the short gut context. The short gut context is that you do anticipate that short gut won't always be short gut, and so therefore there is potential to come off parenteral nutrition. For whole gut aganglionosis, and most of the pseudo-obstruction group of patients, you're not expecting this gut to ever work. So this is a life of parenteral nutrition, potential for transplant, but actually more likely a life of parenteral nutrition. Intestinal transplant isn't really indicated unless you've got good reasons why you can't continue on PN. But the combination of the fact that actually, yes, he had intestinal failure, but also he was going to develop renal failure at some age, led to quite some discussion about what we should do next. And it was clear there was a real disparity of quite strong opinions about what should be offered compared to what shouldn't be offered. Thinking particularly about supportive care only with a palliative view in mind, or actually going all in and offering full treatment for everything. So I think it's fair to say that as a team we struggled to reach a consensus. So we went to the ethics team, who provide us with a helpful framework of how to work through this problem, and we were really honest with the family. The family were well aware that we had different views, that we were going to the ethics team, and we shared all that with them. I think some families that might be really hard to do. This family were, amazing really at A, the support the parents had by an extended family, and B, the parents' ability to take in information, process it in actually quite a clinical way, and come up with decisions. So they decided to keep going. Else it would make a very short case, I guess. So we quickly got them trained up on PN and got them home. And I guess you've seen on some of the other slides that we've been sending people home on PN age 6 months. He went home at 9 weeks old, which I don't think I would do again. But we were doing this because we didn't know what the future held. There was the possibility that actually he could be in with life-threatening enterocolitis within a few days. And so what we really wanted to do was get the family out of hospital in a safe way, and for them to have some good quality of life as a family, because that's what we'd identified as being important. So the palliative care team were really helpful in parallel planning here and actually thinking about what is important quality of life for this kid and also for his family. So the challenge with getting someone out so early is that actually requirements are changing so quickly, and for us to provide PN at home, there's a lead time of about a week to 10 days between us writing a script and it being delivered at home, and the rate of growth is so rapid in these first few weeks that as soon as you write a prescription, it's pretty much out of date. So I was reviewing him pretty much every 10 days, in bringing him up to hospital, doing his bloods, doing his weight, in order to try and do this in a sort of safe way. Overall, he's done all right. So like the first year, I think he had one episode of enterocolitis. I don't think he's had any subsequently. He has had a couple of UTIs. His renal function did take quite a significant hit at one point. And what we weren't sure about there was that because actually his kidneys are failing already, or is it because we're poisoning them with PN? And so as part of that process, we did send him to our transplant centre, which is Birmingham, to have an assessment, simply so that parents could explore, well, what are the potential options? And we still are exploring potential options all the time with him, in terms of, well, if his kidneys fail, what would we do? Because we don't think that an isolated kidney transplant would be doable, because we don't think we'll be able to manage the immunosuppression, because absolutely nothing goes through his gut. So could he have peritoneal dialysis? Yes, he could. Could he have hemodialysis? Or possibly with PN. It's a bit of a challenge. Could he have a multivisceral transplant? So could he have small bowel, if he needed it, liver and kidney? Yes, he could. Probably the parents don't want that. And although as time goes on, it becomes harder to actually say enough's enough from an intervention perspective for a child who's got life-limited problems. Actually, parents are amazing at remaining quite clinical around their decision making, and the conversations that we're still having on a not infrequent basis with this family, where they're at the moment is prolonging his life simply so he can be with us for longer seems selfish if actually it's going to be inflicting operations, more trips to hospital and all the rest of it, when actually what they see as important for their family and their quality of life is family time together. So really interesting. What happens with that small element of renal impairment that he had is actually, it turns out we were poisoning him with his PN. So we've reduced that. The challenge that we had for a while was actually, having reduced that, are we still giving him enough nutrition for growth? Because clearly, again, one of the indications to step up from a renal perspective is if kids with renal disease aren't growing adequately. But actually, he's not growing quite as well as he was. Probably becoming a bit fat, but he's doing okay. And yeah, he's now 3. He's been all right so far this year. He's had a few sort of grumbly bits. We're not quite sure what that's about. And there's the possibility of doing an ileostomy just to try and see whether that will provide more drainage for the bowel that he has. Any more decompression. He's got a gastrostomy which is on free drainage all the time. He does like a drink. He likes a bit of food. So he sips on water or juice or squash or whatever, and he takes sort of bite dissolvable things, skips, Wotsits, those sort of things, and he can demolish a packet of those, and it just all comes straight out of the gastrostomy, sometimes blocking it up a little bit. But overall, he's developing fine. He goes to nursery. He's part of a family. He has his PN overnight, and he's doing okay. There he is. That was probably, I think, it's his first birthday, probably. We need to get some more recent ones from him. So the last case I've got to discuss is a 29-week. Mum has congenital cardiac disease, but this baby was coming early. There's a big placental clot. She got quite bad necrotizing enterocolitis, so ended up with a laparotomy. Found to only have about 30 centimetres of small bowel that was any good, but did have an ileocecal valve and the whole colon. So again, she was transferred down to the Children's Hospital. She had a stoma closed while she was with us, and got discharged home about 6 months of age. She'd only been home a few days when she got really sick. Ended up being helicoptered into us with sepsis, and she had a further episode of sepsis at about 10 months of age that put her in PICU, and she had lots of admissions with sort of blockages and damages to a central line. And that's one of the problems that we see in kids on home PN is actually managing lines. So that's probably the biggest thing that we worry about. So line sepsis is associated with liver disease, with worse prognosis, and if you have children who need recurrent lines replaced, you can eventually run out of new line sites to use. So when that happens, that's when the only real indication now about thinking about intestinal transplant is lack of lines to provide PN and liver disease that's got really bad. But that was her sort of bleak spell. And then over the last 18 months or so, we've been gradually weaning her PN. And what's been a game changer for her, as with a number of kids we've got, is getting some blenderized diet in through the gastrostomy. So she's all right with eating, but she just really can't eat enough. But actually the blenderized diet enables a way of getting that in. And she's recently stopped PN, and a central line's come out. So she's about 4, and she's completely off PN. She's doing fine. So that's with 30 centimetres of small bowel, not actually needing any further bowel lengthening procedures or anything else. She's PN independent, which is great. So a brief bit about outcomes. So this is a slightly clumsy slide I pulled together using data from a New England Journal of Medicine article by Chris Duggan that basically shows percentage survival of children with intestinal failure, and the size of the cohort is the size of the ring, and you've got year of publication. So what you can clearly see there is that actually there is increasing survival over time, and actually it's larger cohorts that we're seeing that increased survival in. So that's fairly sort of crude data. So a bit more detail. So this is 3 long-term home PN cohorts, so Great Ormond Street, UCLA and the Necker in Paris. And so you've got survival on the y-axis and years on the x-axis. And so you can see that actually 20-year survival is around 60%. So this is kids transitioning to adult services. And these data are not exactly current either. One of the challenges that we have is actually contemporaneous cohorts. We just don't have good data to say what the long-term outcomes are. So then if you look at gut length, and what does that mean? So this is the UCLA data broken down by those that have got bowel less than 15 centimetres and those that have got more than 15 centimetres. So this isn't survival, this is those that remain dependent on parenteral nutrition. So you can see that actually those that have got more than 15 centimetres of bowel, actually most of those, 90% of those are getting off PN completely. Those that have got less than 15 centimetres, actually 40% of those are getting off PN completely. So that's ultra short bowel, less than 15 centimetres. UCLA may be very good at that, but I think actually the rest of us probably are getting better with managing these patients. So why are we getting better at managing these sorts of patients? Why are we seeing outcomes improving? So this is UK data, and it's just simple stuff from a couple of years ago. So we're seeing more patients, and we're seeing patients in fewer centres. There's been lots of talk about, well, is it the type of lipid, and does that reduce how much liver disease you get, and everything else? No, because in the States they still use lipid that we would sort of generally not use. It's to do with actually having teams of people dedicated to look after these patients, focusing on the basics, making sure that line technique is good, that line sepsis is kept to the minimum, that nutrition is delivered in appropriate amounts and not excessive amounts, that we try and make sure we get nights off PN early on, that we support the enteral nutrition, that we have psychologists that look at trying to promote feeding and trying to manage parental anxiety with feeding, and that we have better links with the surgeons, that we're doing more appropriate interventions timed at the right time. So it's all of those things that add together, making sure that actually the children are managed in specialist centres that can provide all of that, is what makes the difference. Clearly massive rise in the number of children receiving home PN. I mean, we're not entirely sure about the 2012 data, whether or not we had complete data capture. The 2018 data is the best we've ever had. We know that because I managed to get the corresponding data out of the home care companies to tell us how many clients they had, and it beautifully matched the number of home PM patients we had. So we definitely had complete data collection in 2018, which is encouraging. And this is an overview of UK data. So this is the 2018 EBANS data, which shows how many patients are still active in purple, how many have weaned in green, how many have died in sort of a pinky colour, those that have transitioned in orange, and those that have transplanted in brown. So very few transplants, so it's not even worth getting into a discussion on the neonatal unit about intestinal transplant. It's just not appropriate. That actually, yes, a large number of patients are still active, but actually, a quarter of the short bowels have been weaned off. Not surprisingly, the NMD, neuromuscular disease, not many of those have been weaned off, and those are mucosal disorders. So other mucosal disorders, OMD, chronic enterocyte disorders, CED, not necessarily very many of those weaned off. So to wrap up, so from my perspective, short gut length doesn't equal futility of treatment. So we have our own experience of kids with very short gut coming off TN, and that's backed up by literature that's out there. We know that those with gastroschitis, some of those, they're likely to have longer duration of needing PN. I think the challenge with palliative care that we have in gastroenterology is that if people are dying from intestinal failure, what's going to be the mode of death? Is it dehydration? Is it malnutrition? So it's working out a comfortable way of managing that. So yes, similar to the first point, but long-term survival with ultra short gut happens, and even enteral autonomy is possible. It's really important that we have joined up discussions with all the teams involved in the management of these sorts of patients. So surgeons, gastroenterologists, neonatologists, other teams like renal if it's a renal problem, involve ethics teams, involve families in discussions, involve palliative care, in order to enable sort of parallel planning of what's going to happen at different stages. I think from a neonatal perspective, avoid talking about intestinal transplant. It still seems to be the thing that people want to talk about. Intestinal transplant is not on our radar until parenteral nutrition isn't working, and that is unusual. We do have it, but it is unusual. I haven't talked about tetraglutide, which is a hormone treatment that is possible. We may get access to that gives us another route of getting children off parenteral nutrition. There's other developments like that are coming. Stem cell transplant, mesenchymal stem cell transplant into gut scaffolds is something else that's out there, but none of these are actually accessible to us reasonably at the moment. Thanks very much.
Okay, that was really good, Tony. Thank you very much. I've moved into the sun because it's a little bit warmer here, and I'm actually sitting in front of this pod. I'll show you. Quite nice, isn't it? This is in the hospital garden. It's a place where you can drink a cup of coffee. Maybe perhaps not in COVID times, admittedly. Anyway, thank you for that, Tony, and hopefully it's given us a real flavour of the kind of things to think about when these patients come around. Okay, now we're going to, obviously the whole theme is on babies who need a little bit of extra care, but we're moving on to a slightly different subject now and thinking about babies with respiratory problems who need home oxygen, and one of the key ways of sort of looking at that are these overnight saturation monitoring or sleep studies. Dr. Hazel Evans has got a particular interest in this. She's actually a respiratory paediatrician consultant from Southampton, and has actually been doing some work to both standardise, find normal values, and let us understand really how to use this tool potentially more effectively. So I'm going to hand over to Hazel now, who will talk you through her slides. Again, remember, just looking at the side there, you can give us comments or ask us questions, ask Hazel questions about her talk, give us comments about how you're enjoying it so far and things. And yeah, so I suppose that's where we are. I'll hand you over to Hazel.
Hello, my name's Hazel Evans. I'm a consultant paediatrician in Southampton, and I've got a particular interest in normal oximetry parameters in young babies and how you apply those to wean oxygen in babies with bronchopulmonary dysplasia. I'm going to use this talk really to think about initially about how you might set your oximeter up and how that might affect the data that you acquire if you're measuring oxygen saturations in young babies, and also using modern technology, how we have an understanding of normal oxygen saturation parameters and how you might use that to wean oxygen in babies with BPD. So BPD, as most of you will know, is defined as either an oxygen requirement at 36 weeks for babies that are born before 32 weeks, or an oxygen requirement at 56 chronological days for babies that are born between 32 and 36 weeks. And the severity of BPD is determined by the extent of the oxygen requirement and whether the baby is ventilator dependent. And whilst survival rates for babies born extremely prematurely have increased, there are around 1,000 babies a year that develop bronchopulmonary dysplasia, and the majority of those are discharged in oxygen. In 2011, Rob Premack did a survey across the United Kingdom, and of all the babies that were in home oxygen, approximately 2/3 of those are receiving oxygen for bronchopulmonary dysplasia. And these babies have a high healthcare utilisation. About 50% are admitted in the first year of life, and they have double the costs, healthcare costs, compared to their peers during the preschool period. So when we're thinking about who needs oxygen, then we've got a number of guidelines that we can refer to, and these span a 10-year period. The British Thoracic Society guidelines, I'm sure many of you are aware of, are published in 2009, and more recently in 2018 we had publication of the American Thoracic Society guidelines and also the Australian Sleep Association guidelines. But rather tragically, in the 2018 guidelines published by the ATS, they stated that there remained a striking lack of empirical evidence regarding implementation, monitoring and discontinuation of supplemental oxygen therapy. And Ian Balfour-Lynn, who I'm sure many of you will know, he's an eminent respiratory paediatrician from the Brompton, really in an editorial in The Lancet, stated how unfortunate it was that the evidence base really hadn't progressed in the 10 years since the British Thoracic Guidelines were published. So based on a lack of evidence, the ATS recommended that for children with bronchopulmonary dysplasia complicated by chronic hypoxemia, home oxygen should be prescribed. And they defined chronic hypoxemia as spending at least 5% of the recording time with saturations at or below 93%. So given that the guidance is currently not evidence-based, Alison Gard, who's an ST4 in Bath, and many of you may know, sent out a survey monkey to respiratory and neonatal networks in England and Wales and asked for details on current practice in association with oxygen initiation, oxygen weaning, and also some technical considerations in terms of the monitoring that was undertaken. We had responses from 44 And you can see here that approximately 50% of units use mean saturation as an important marker of decision on which to base initiation of oxygen. But when you think about cut-off criteria of percentage of time with low saturations, there's a huge variability from people having cut-offs of 95% to people having cut-offs of 88%. And you can see from the graph that people were allowed to put in more than one response. And the same as for oxygen weaning as well, a very similar pattern was produced. Technical considerations. Well, we asked how long was felt to be deemed to be an adequate period of recording, and about 50% of respondents said that they felt 6 hours was appropriate, but the other 50% gave a very wide spread with a significant proportion being unsure. And when we asked some more detailed information about the averaging time of the oximeter that they were using, more than half respondents didn't know what their averaging time was, and I'll come back to that shortly. So over the last 10 to 15 years, there's been a massive expansion, growth in understanding around sleep disordered breathing in infants and children. The British Sleep Society has now expanded to include the British Paediatric Sleep Society, and we've had better oximeters over the last 10 years, and the one that I'm showing here is the Masimo oximeter. And the benefits of the Masimo oximeter is it's able to exclude motion artifact. And in this study, the patient acted as its own control. They had two oximeters. One hand was kept still, and the other hand, the subject was encouraged to move their fingers around to elicit motion. And you can see here that in the top graph, that relative to the control, the Masimo oximeter was the dark line was able to accurately detect saturations that were in the normal range, and the control is this very thin dotted line here. But when you have the effect of motion, this motion interferes with saturation measurements, and so you get this wiggly line because the artifact is not excluded. Induce a hypoxic event, if you're able to exclude motion, you can accurately detect this induced hypoxia relative to the dotted line here on the control hand. But in the presence of motion, these oximeters were unable to accurately detect both the nadir of the hypoxic event and also the length of time that it lasted. These study looked at a range of oximeters, and you can see that the Masimo oximeter, which is able to exclude motion artifact and poor perfusion, had by far and away the best sensitivity and specificity for accurately detecting saturations compared to a control measurement where the subject wasn't moving. Box here, you're accurately able to detect the genuine desaturation here in the solid black line because it's not blunted out. But if you decide to set an averaging time at 16 seconds, and this is where the oximeter starts to read, and it's reading back to here over 16 seconds, what you get is the normal saturations averaged out with the desaturation. You get a blunting of effect, so you get a lower baseline and you miss the depth of the desaturation. So the averaging time has a really big impact on both the baseline saturations if you're having lots of desaturation events, and it blunts the depth of the desaturation. And this is really important in young babies, and the reason it's really important in young babies is because babies have short central apneas. You can see here by an absence of flow on this cardiorespiratory study, and this absence of flow here, and this is associated with followed by short desaturation. Between these purple bars, that's 10 seconds, And so you can see that this desaturation is approximately 3 to 4 seconds. So if you have a long averaging time, you'll completely blunt out that desaturation. And this paper by Ahmed et al. Demonstrates this nicely. The lilac bars represent short averaging times. You can see that you're much better able to pick up the depth of a desaturation, with many more desaturations down below 50% with a short averaging time compared to a longer averaging time. You're able to pick up much more of these short desaturations with a short averaging time. And this is a study by Terrell et al., which demonstrated that in young preterm infants, as outlined by the blue bar, and term infants in the black line, that if you have a short averaging time here of 3 seconds, you are able to pick up many short desaturations. As preterm infants is about 50, relative to the term infants of about 25 desaturations, and that's the number of events per hour. But if you extend your averaging time, so you're only able to pick up desaturations lasting 10 seconds, your values that you're going to pick up are significantly less in terms of the number of desaturations per hour. This was a study that we carried out in young healthy term babies, and what you can see in the top line is the oxygen saturations in red, and you can see that during active sleep, which is denoted by increased heart rate variability in the blue line, that there are clusters of very brief desaturations on top of a normal baseline. In quiet sleep, where you have less heart rate variability, the oxygen saturations are maintained in a high normal range. And so using these new generation oximeters with short averaging times, over the last 2 years, there start to be published some data in both healthy preterm infants from 35 weeks gestation and the graduates of babies born extremely prematurely. And what you can see with the healthy infants is that actually mean oxygen saturations are very similar to older children, with saturations 97 to 98%, and that really doesn't change over the first 4 months of life. But what is very noticeable is the 3% desaturation index, and you can see that in babies, preterm babies at 40 weeks gestation, these babies have on average 3% desaturations per hour, and by 3% desaturation I mean a dip of 3% from their baseline. But over the first 4 months of life, there's a gradual reduction in the number of events that occurs every hour. So by the time you reach 4 months of life, the average is reduced from 33 down to 14 events per hour. And that's likely due to maturation and reduced central apneas and short pauses in breathing. As a result, these reduced brief desaturations. And whilst healthy preterm infants have 32 desaturations of events per hour, what we see in the babies, the extremely preterm infants that have graduated to become to term, these babies are more likely to desaturate with brief pauses in breathing. You can see here that at 37 weeks, 80 events per hour and 55 events per hour at 40 weeks, as compared to 33 with the healthy preterm group. And I think that's probably because the lungs are still the lungs are more vulnerable, and so the impact of a short pause in breathing has a greater effect on oxygenation. Despite the increase in the desaturation index, the mean saturations again are very well maintained between 97 and 98%. So does it matter? Does intermittent hypoxia, is it important? Well, again, we're getting some increased evidence in relation to that. And this was further data extrapolated from Terrell's paper, and what he looked at was healthcare utilization and compared the babies that had more desaturation events to those that had less. And when he plotted these desaturation events in relation to healthcare utilization, he demonstrated that babies that had more desaturation events were more likely to have increased healthcare utilization. And you can see this on the graph on the left here. The blue line denotes the number of desaturation events for the group of babies in the top tertile for healthcare utilization, and the red line represents those in the lower tertile for healthcare utilization. And you can see that the 3% desaturations, for example, were at 65 to 70 for those that were having more healthcare encounters relative to the about 40 desaturations an hour for those that are having less healthcare encounters. And when we think about growth in nutrition, this was a study on rat pups who were exposed to intermittent hypoxic events, and the ones that were exposed to intermittent hypoxia had impaired growth for the first 3 weeks of life, but then a catch-up at 28 days. Perhaps most interesting is the data on cerebral oxygenation, and this study by Rosemary Horn's team undertook a polysomnography on babies, and alongside that used near-infrared spectroscopy to look at cerebral perfusion and tissue oxygenation. And what they found was that immediately following central apnea, there was a reduction in brain perfusion. But what was really interesting was that this was most marked at about 5 to 6 months post-term, and that's probably because the brain is more metabolically active as the baby grows, and so their short central apneas have a greater impact on tissue hypoxia. So when we think about all this, how can we set criteria for initiation and weaning of oxygen? And it's really important that we have to strike a careful balance between understanding what's normal for babies based on the normal reference ranges that we're starting to acquire, understand that oxygen is a drug and it has risks in the household and we shouldn't prescribe it unnecessarily, but at the same time we want to try and avoid the impact of intermittent hypoxia both on growth and on neurodevelopmental outcome, along with healthcare utilization. What do we know about baseline saturations? We know that term and preterm infants have normal mean saturations, as we would expect for older children, at somewhere between 96 to 97%. We know that they spend really short periods of time with saturations below 90%, and certainly the term data, babies were spending less than 1% of the time with saturations below 90%. Graduates from the extreme preterm cohort spend a little bit longer with saturations below 90%, but certainly no more than 4%. And we also know that because we're able to capture these fleeting desaturations, that these babies can desaturate down into the 80s very readily for term infants, and for preterm infants at term can desaturate down into the 50s and 60s. But there's a rapid change, this rapid period of maturation, and so when we're looking to initiate and wean oxygen, it's really important that we refer to those reference ranges which change over time. When we're thinking about mean saturations, one of the things we need to remember is that if we keep mean saturations relatively high, then we're less likely to get episodes of intermittent hypoxia. And this was demonstrated by one of the randomized controlled studies, which set either a low oxygen saturation target of 85 to 89% or a high target of 91 to 95%. And they measured the number of ischemic intermittent hypoxic events per patient per day. I think it's important to note that the definition of a hypoxic event was desaturation below 80% lasting 10 seconds. So predates our current recording mechanisms that we're using for measuring intermittent hypoxia. But I think what is interesting was actually as the baby got bigger and grew, the difference in the number of hypoxic events between those that were kept in a low target, having somewhere between 100 and 150 events per day, and the babies that were kept in the high oxygen target, having closer to 50 events per day, seemed to get bigger as the baby matured. And so I think that really raises the importance for us of keeping mean saturations in the normal range. And so based on all the data that has been published over the last couple of years, we've come up with some targets for both initiation and weaning. It's important that when we talk about these targets, this is based on using modern oximeters with short averaging times. And you can see here that this data is based from 37 weeks upwards up to 4 months of age, and we expect mean minimum saturations to be 95% throughout, and we expect the percentage of time at which saturations are below 90% again to be very minimal, certainly less than 3% of the time. But important to note, if you look at the 3% oxygen desaturation index, there's a very significant change from 37 weeks up to 4 months post-term, and that's due to maturation and reduction in central apneas. And this is based on data from either healthy preterm infants or normal term infants. And when we wean oxygen, we have a clear pathway that we follow. Prior to discharge, we perform oximetry to determine the optimal discharge flow rate, and we perform an echocardiogram to look for pulmonary hypertension. And then we do oxygen saturation studies every 3 to 5 weeks, and we do them overnight and in the child's home with the alarms on. Night 1 we do in their current oxygen prescription, and then night 2 we wean by 0.1 litres per minute. There's good evidence that you can wean at this rate. Certainly babies over 2.5 kilograms entrain a lot of extraneous room air when they're breathing in. So actually the amount of oxygen that is inspired is significantly diluted from that which you think you're delivering via nasal cannulae, which is why you can wean oxygen more rapidly in larger babies than you can in very small babies on the neonatal unit. Once the baby's down to 0.1 litres per minute during the day and night, we then advise weaning into air during the day, and that's done by spot saturations when the baby's awake and feeding to ensure that the saturations are at least 95%. And once the baby's in room air during the day, then we'll undertake a study overnight in room air. And once the baby, we're happy that the baby's saturations meet our target ranges in air, then we'll remove the equipment and the baby will be discharged from the sleep service. So to summarize, I think it's really important that you know the settings of your oximeter when using it to monitor your oxygen saturations. Developmental immaturity results in significantly different desaturation indices when compared to older infants, but they rapidly change over the first 4 months of life. And it's and previously reported guidelines, recommendations from guidelines are probably not appropriate if you're using a modern oximeter with a short averaging time. So that's all I've got to say. Thank you. I'd be happy to take any questions at the end if there is an open discussion. Alternatively, if you have questions and you want to email me, my email address is hazel.evans@uhs.nhs.uk, or I'm sure you can get it from Steve. But thanks very much for listening.
Thanks, Hazel. That was really good. Again, remember, if you haven't asked a question and you want to, then put it on the side there, and either Hazel or one of us will try and get back to you to answer your questions. I've moved again, as you can see. I thought I'd show you some of the flowers here in the hospital garden, which are really nice. Anyway, we're now going to move on to look at some of the practical applications then of managing home oxygen. And Joanne Broderick and her team down in Torbay have actually done quite a lot of work on this and written a new guideline, which I know they found really helpful. I know we've recently updated our guideline in line with it. Anyway, she's going to talk us through some of the practical considerations. Again, remember to ask any questions that you want to in this box over here. And otherwise, I will come back to you now after the talk. So, Joanne, over to you.
Hi, my name's Jo Broderick. I'm a community children's nurse from Children and Family Health Devon in Exeter. I've been asked to present to you the development and implementation of an oxygen weaning guideline that we've commenced for babies in the community with chronic neonatal lung disease. We've been weaning babies off oxygen for a long time in our service, but in 2014 we decided that it was time to look at the way we were doing it because it felt that there could be some improvements to be made. When we looked at how we were doing it, the weaning process was protracted, unstructured, consultant-led, and there was no consensus of opinion. There was inequity amongst patients, inconsistency between the CCNs undertaking the weaning process, and ultimately there was no governance in place. We also found that the impact this was having on our babies and families was that it was potentially unsafe, that the episodes of care were very long, which encouraged reliance and a disease burden. Having a baby at home on oxygen is an emotional and stressful time. It's impractical and families can't plan their lives. We also found that some of the babies weren't reaching their global development potential. There were also inefficiencies found within our service. The long episodes of care required intensive nursing input and hours. Delays were being faced, and this was impacting on the CCN's caseload. It prevented them from taking new referrals. The equipment we were using was not fit for purpose, and the cost of consumables was high. Naturally, we cover a large area in Devon, so the number of visits per episode were filling our days and preventing us from seeing other patients, and families were reliant on waiting in for our visits. So we saw an improvement opportunity. We saw an improvement could be made to the safety, to the governance, to the upskilling of the CCNs, giving them autonomy and empowerment, empowering our families and providing new guidance which was clearly quite highly sought after. There was potential for efficiencies across the board, improving outcomes for families and sharing good practice. I took this on because I felt very passionate about it. I could see where the improvements could be made, and I wanted to be an advocate for the families, the babies and the staff that I worked with. I had a vision and I embraced the new skills and challenges that it would bring. I used the PDSA cycle to help me plan how the new weaning guideline was going to be produced. It gave me a framework, a structure and guidance. So I started by planning. I did some research. There was very limited evidence around this subject. So I needed to liaise with the multidisciplinary team, the families already involved with weaning, my colleagues and professional colleagues nationally. I then wrote a guideline which I shared with all of those groups again, and it was agreed. A consultant paediatrician from the Royal Devon and Exeter was very supportive in this process. I needed to write a business proposal in order to purchase new equipment in order to allow the new guideline to be safe. And I rolled out training on the guideline, implemented it, and this was all invested in my own time. When we start new things, it's important to measure outcomes. So I needed to write an audit tool. I collected information within the first 6 months of introducing the guideline and analysed the results. I liaised with the families using it and the multidisciplinary team and my colleagues. We had some results and we discussed these. We realised there was evolving work and further development to be done. There was new evidence coming out all the time around weaning babies of oxygen, and we looked at this evidence and made recommendations according to them. So the guideline itself is a partnership approach with both the family and the multidisciplinary team. Back in 2014, some babies were being discharged home without a CCN, either knowing about them or being invited to attend a discharge planning meeting. So part of the guideline, importantly, dictates that a CCN must attend a discharge planning meeting. This is so that an agreed plan of care can be reached between everybody. The guideline itself is a structured, planned and incremental process. It's important to say that if the baby meets the criteria to be placed on the guideline and is a straightforward case without any complications, that they continue to follow the guideline and oxygen is reduced in a stepwise approach following overnight trace data analysis. Again, there is conflicting information around this subject, but overnight traces is the agreement that we came to. There are clear parameters and they are easy to follow. The CCN is guided, the family are informed and empowered. We were able, with our new equipment and our software that we purchased, to do home downloads. This was the first time we'd been able to do this, and it was going to eliminate one whole visit to the family, thus creating service efficiencies and improving outcomes for our families. The nurse downloading in the home is able to analyse the results there and then and make immediate oxygen adjustments according to the results obtained. And the nurse is also able to do the follow-up monitoring to ensure the baby is safe. Again, this has reduced a further visit to the family home. This planned care allows the family to plan their lives, and it allows the Children's Community Nursing Service to plan their cases and their caseloads and their diaries. All this change brought about an increase in education to both staff and families about oxygen. There was better documentation, there was improved communication with consultants, there was now a structure and supportive measures in place. Risks are being assessed on every patient. Checks and home oxygen packs have been introduced to the initial nursing visit within 24 hours from discharge. The process is no longer ad hoc, and oxygen is also being removed from homes, where before oxygen was being left in homes for a very long time. Importantly, overall, babies are now being seen. It was important to gain feedback from our families after the first 6 months of introducing the guideline, and this feedback told us that families felt from the discharge planning meeting onwards involved and equipped to take on the forthcoming months ahead of them. These families have already had a long stay in hospital and can be exhausted, but feeling involved and empowered and knowing the process, and in some ways having expectation about the road ahead allowed things to feel a little bit less daunting. It gave them some strength and resilience to get to the end of their oxygen journey. This increase in oxygen knowledge and education for families and staff created a feeling of safety. The CCNs are highly skilled paediatric nurses, but they weren't experts in oxygen. This process has enabled them to learn more about this prescribed drug and use it safely. There was clarity, there was clinical support structure, and there is and risk is being assessed as an ongoing thing. There is now structure and no ambiguity. CCNs are all doing and saying the same things, giving clear direction to our families. The expectations are set, but they aren't set too high. We always make our families aware that things can happen to delay the process. There is a consistency between the multidisciplinary team. As I've said, there's no room for ambiguity. There is equity amongst our babies on oxygen all around the county. By introducing this structured approach, visits to the patient's homes per episode of oxygen care or journey have naturally been reduced, therefore minimising interruption and being less intrusive into our patients' lives. It allows them to lead their normal family life. Despite giving our families some structure and expectation, they have still become surprised and delighted when oxygen has finally come off at the speed that it has happened. They are always warned of the delays that can occur, but often when these babies are ready to wean, they usually declare themselves quite positively. So babies are free from oxygen paraphernalia a little bit sooner. As I've said, the families can resume normal life. This impacts on the whole family, including siblings. The babies are able to access baby groups and social activities that they wouldn't ordinarily be able to access, such as swimming, for example, and reach their developmental milestones. As we know, family stress impacts on siblings. It prevents them from engaging in their normal socialization. So therefore, by removing oxygen a little bit quicker, it allows them to resume their normal life. This graph is a visual representation. It's a snapshot of time that was taken before and after we introduced the guideline. The blue columns are before and the red columns are after we introduced the guideline on the flow rates that you can see along the x-axis. The other benefits I want to mention are that actually by introducing the processes that we introduced, utilising the guideline, actually meets all CQC regulation standards of being safe, effective, responsive, caring and well led. The average number of weeks it took to wean a baby in 2014 was 22. Using the guideline, the average number of weeks to wean a baby from oxygen, obviously dependent on their flow rate, is 8.75 weeks. We have also successfully managed to reduce nursing hours per weaning journey from 168 to 68 on average. There have been some cost savings and of course cost avoidance, by increasing the time that we can spending with other families, allowing for new referrals and reducing travelling time, reducing the number of visits to our oxygen babies. There are no longer delays in communication with our consultant, and we are using less consumables. We are using high quality probes and high quality equipment. The process is family centred, which of course means that it's based in the place that the baby lives. This is where they function well, this is where it is practical and convenient, and there are less hospital visits. We have over 250 years paediatric nursing experience in our team, and we were ready for this autonomy. We have all learnt new skills. I have learnt new skills, and it has taught me to keep going and don't give up. We are now using up-to-date communication methods which meet information governance. They are prompt and effective. We are relieving some burden from the consultants in secondary care, allowing them to see more patients. We are allowing our service to take on more work with no increase in resources. There were, of course, challenges that I had to face. We needed to use the best evidence available. Unfortunately, there was a lack of high quality evidence. I needed to liaise with the multidisciplinary team to reach mutual clinical parameters. Since we've written this guideline, the BTS guidelines have been superseded by the ATS guidelines, and currently the parameters we use meet those recommendations. But it has prompted wider discussion, and there has been further development of our guideline. We used Profox software. Although it was effective and it met our initial criteria, we have now switched over to Visi downloads because this meets with the processes and is in line with the processes that secondary care use, and continuity is important, and it enables the consultants to feel confident in our data analysis. We know that studies are being done to determine in preterm infants at neonatal discharge the prevalence of intermittent hypoxia as measured by the oxygen desaturation index. We have now introduced the desaturation index of 4% from baseline measured in our pulse oximetry, and we exclude movement to enable our data analysis to be really accurate, or as accurate as it can be. Accuracy of oxygen monitoring is a challenge. Pulse oximetry is not an exact science, and there is some ambiguity in both adults and paediatrics, but I feel that we have gone some way to making what we do a lot safer and a lot more robust. Confidence in the pathway, the guideline, has grown between the CCN team that I work in and the neonatal colleagues. This has taken time, and it continues to evolve as more evidence becomes available. Before I move on to the guideline itself, I want to talk about how we wean our babies. So through mutual agreement, it has been agreed that we will perform overnight oximetry, and that when oxygen is delivered greater than 0.1, we will repeat our overnight traces at 2 weekly intervals, reducing the oxygen in 0.1 increments. When the baby reaches 0.1, we then perform overnight oximetry every 7 days, and reduction in oxygen is made in 0.02 increments until we reach air. So the guideline is split into the referral process first and foremost, and the baby must meet the criteria to be entered onto the guideline, as stated: post-gestational age of greater than 36 weeks, and they must also have no other additional problems. I call these babies feeders and growers. We are then invited to the discharge planning meeting on the neonatal unit. A named CCN will attend, and everyone at that discharge planning agrees the planned approach. A discharge date is set and the infant is discharged home, and a care plan is put in place. The community children's nurse will visit within 24 hours of discharge. This enables the CCN to undertake initial assessment, provide required education to the family, and perform a spot pulse oximetry of the baby. The saturation monitoring process. So, a overnight pulse oximetry trace will be undertaken 7 days following discharge. Those results will be analysed by the CCN. Desaturation index will be taken into account, and those parameters are set there for you in the third box down. If oxygen saturations are at or above 93% for greater than 95% of time, oxygen can be reduced. Where possible, once the first initial oxygen reduction has been undertaken by the CCN to show the family how to do this, further adjustments can be made by the family themselves, and confirmation of these provided electronically to the CCN. The CCN liaises with the consultant to provide a clinical update. If the oxygen trace shows that oxygen saturations are below 93% for greater than 5% of recorded time, there will of course not be a reduction in oxygen. If the baby is showing clinical signs of respiratory distress, the CCN will react accordingly, but will also inform the consultant for a clinical decision. The parent or guardian will be informed of the findings and any necessary changes. Any increase or decrease of oxygen, Air Liquide will be informed by WHO. So in summary, we have a weaning guideline that was very much needed. It was a document that I felt provided our service with the safety aspects and the governance and a structure that we very much needed. It is recognised that the work we've done continues to evolve and that the lack of high quality evidence is changing, and this is exciting times. There has been immense learning for everyone involved, and we continue to learn from our oxygen weaning babies in the community. I have outlined to you the improved outcomes for families and patients and the overall service efficiencies that have been made. The improvements in communication have been tenfold, and the future development of weaning babies with chronic neonatal lung disease in the community continues. We are always developing and looking at our software and analysis, and we continue to do so. I have become a member of the Paediatric Pan London Oxygen Group, who have created a discharge weaning bundle successfully and are now looking at weaning babies from oxygen in the community. My work has been shared on the NICE Learning platform, which has brought about wider learning within this country and abroad, and the work that I've done has been publicised in Nursing Children and the Young People Journal. Thank you for listening.
Thanks, Joanne, that was really good again. So hopefully everyone's got a better idea of not only some of the pitfalls with home oxygen saturation monitoring that Hazel filled us in with, but now some more practical ways of how to use it. Have a look at the comments and the questions over there, because they may actually answer some of your questions. Anyway, that brings us to the end of this afternoon's webinar, the summer meeting of the Southwest Neonatal Forum. Just to give you some dates, The next meeting is scheduled for the 6th of November. Just think about that. Won't be sitting out here, I don't think, on the 6th of November. Anyway, whether we will be able to, or at least some of us will be able to meet face to face in Taunton. We have got a booking there. I'm minded to look at the problems of the extremely preterm infant, although I haven't completely got the programme together yet. So feel free to email me and stuff. Otherwise, hopefully, you've all found this really successful, and I will undertake to, if we do meet up face to face, I suspect we may well not all be able to meet up, and I will record it and load it up onto our YouTube channel so people who aren't there can watch it later. Anyway, stay well everybody. Hopefully it won't be too long before we can meet together as well. Again, historically, remember, we do have posters and things at our November meeting, so again I will work on ways to try and do that as well, which I think we may well be able to do via this sort of YouTube channel. Maybe getting people to give us, I don't know, 2 or 3 minutes talk in front of their poster as a kind of selfie. Yeah, I suppose I found it quite an interesting experience, sitting here in the hospital garden, watching the presentations and things. So, and hopefully you have all too. So, as I said, look after yourselves, stay well, and I'll see you soon.